tonight we will discuss sinus headache and allergy with Dr. Vincent Martin. Please feel free to start submitting your questions at any time. Dr. Martin, thank you for joining us.
Thank you. It's a pleasure to be talking to you guys tonight. As was mentioned, the topic is going to be on sinus headache and allergy. I'm just going to show you about 6 slides or so, maybe 7, to kind of acquaint you with the topic so that we kind of all have the same language, and also to key you in on some of the new research that's been done in the area. Now, within the headache field, there's a lot of, I think, misunderstanding about sinus disease and headache. In fact, most neurologists in the field and headache physicians don't really believe that sinus disease and or allergies and or something called rhinitis. Rhinitis is just simply where you have nasal congestion or nasal discharge or postnasal drip that's unrelated to an upper respiratory tract infection or the common cold. But if you look at this very first slide, what you find is there's about 28 million migraineurs in the United States. And there's only about 13.4 million of those patients are actually diagnosed. And actually, you can see that in that little pie chart, that 13.4 million in the yellow. And then when you look at the diagnoses of the other people that they've received from other physicians, what you find is that about 32% of those patients with migraine were diagnosed with tension-type headache. But the most common diagnosis that people receive when they have migraine is actually sinus headache. And this and one other study, which I'll show you here in a minute, has kind of led physicians to believe that every time someone complained of a sinus headache or allergies, that they just had migraines. We'll go to the next slide. So the question comes up is, the headache community would argue that if you have headaches and symptoms suggestive of some sinus problem, whether it be nasal congestion, runny nose, or whatever, that this represents what we call a primary headache disorder, either migraine or possibly tension-type headache. But some evolving evidence would suggest that there may be some other potential causes for these types of headaches. So there's 3 kinds of rhinitis, and I'll tell you what these mean here in a minute, but there's allergic rhinitis, there's something called non-allergic rhinitis, and there's something called mixed, which is kind of a combination of the two. And we'll talk about that. So it's plausible that these forms of rhinitis could cause some head pain. Infections of the sinuses, and that may occur with rhinitis or without rhinitis, could be associated with head pain. And I think that's not disputed within the headache field right now. So if you have what's called an acute sinusitis, where you're blowing out real nasty green or yellow discharge from your nose, and you've got some pain over a sinus, so over your cheekbone or over your forehead or between your eyes, then headache physicians don't dispute that an acute infection, particularly one that has fever, could cause head pain in the area that's overlying where the sinus is. But outside of that, most headache physicians do not believe that diseases of the sinuses actually lead to headache, which is what I alluded to before. And then finally, there's these anatomic abnormalities of the nose and sinuses, and maybe some of the listeners have actually had sinus surgery, but one would be a deviated septum. That's simply where the middle cartilage that divides the 2 nostrils becomes pushed to one side, and that's called a deviated septum. And particularly when that septum touches the outside part of the nasal wall, when those 2 surfaces, or what we call mucosa, make a contact point, then some people believe that can actually generate pain. In fact, that's something that the ear, nose, and throat doctors really would buy into, and another reason why a lot of ENT physicians, if they find these anatomic abnormalities, particularly if it's compressing against a wall of the nose, that they will go ahead and operate and fix these problems in hopes that they will improve headaches. So there might be other ways that these disorders could account for what other disorders could account for sinus headaches, but these are probably the prominent theories currently. Now, if you looked at the next slide, this was a study that was published about 8 years ago in the Archives of Internal Medicine, where what they did was they took about 3,000 patients who thought they had sinus headaches. Now, there are no official criteria for sinus headaches. by our official diagnostic criteria as published by the International Headache Society. So these are people that thought they had sinus headache, based on what their physician thought was a sinus headache, or possibly maybe they thought they had sinus headaches themselves because the headaches that they had override one of the sinuses, or maybe they had some of these rhinitis symptoms like nasal congestion and discharge and postnasal drip that we talked about before. So they had about almost 3,000 patients with these quote-unquote sinus headaches, whatever they truly were. And then what they did was they took a headache interview from these patients and found that about 80% of these people met criteria for migraine. So this led the entire headache community to conclude that all patients that thought they had sinus headaches were just simply migraine. And in fact, a lot of headache doctors even believed that a lot of the rhinitis symptoms that the patients had were just manifestations of migraine. So we'll go to the next slide. The question that they forgot to ask is, why is there such a high prevalence of migraine in patients with sinus headache? Because frankly, if you talk about the percent of patients in the population that have migraine is about 12%. So 80% is roughly, about 7 times that high. So the question is, why would people with sinus headache have such a high prevalence? Or prevalence is just another name for the proportion of patients in a population with a given disease. So in this case, it would be the proportion of patients that have migraine. So why is there such a high prevalence of migraine in these patients? And I would contend that it's probably because these disorders are interrelated, and my guess would be that one tends to modulate the other. Although this, like I said, this is not something that's commonly accepted within the headache field. So now we're going to talk about rhinitis and migraine. This is research that we've actually done. Some of it's, I'll show you some of our research, and I'll point out where other investigators have done research, but we've been doing this study now for about 4 or 5 years, and we're just now getting ready to write up and publish some of this data. But there are 3 what we call subtypes of chronic rhinitis. And I told you what the rhinitis was before, was we get nasal congestion, nasal discharge, or postnasal drip usually, or you get an itchy nose, or you can get sneezing. Those are the 5 symptoms of rhinitis. And there's 3 types. There's allergic, there's mixed, and there's non-allergic. So if you look up to the slide to the left, allergic rhinitis simply means that you've got an allergic trigger. So examples of allergic triggers are, for example, cat dander, dog hair, could be tree pollen, grass pollen, mold, and all these things create a certain type of response within your immune cells that's called an allergy. And usually when people are exposed to these allergens, that's what they're called, they will often develop rhinitis symptoms. So a classic example of that would be that you are cat allergic and you go over to your friend's house, or maybe you have a cat at your own house, and the cat climbs up in your lap, and all of a sudden you start getting, basically, sneezing and runny nose and postnasal drip. And sometimes people even get some symptoms of their eyes, where they get itchy eyes and red eyes, and that's actually called allergic conjunctivitis. So that's basically an allergy of the eye, but we're talking about an allergy of the nose in this case, where you get allergic rhinitis. And then what you have to do is you have to have symptoms in relation to exposure to some allergen. And then you have to go to your allergist or your primary care physician and have allergy tests done and confirm that you indeed are allergic to cats. So if you have a positive allergy test and you have the history that suggests that exposure provokes symptoms, then you have allergic rhinitis to cats. And the same thing could be said for tree pollen. So if your symptoms worsen during the spring, and you have a positive allergy test for tree pollen, then you would be considered to have allergic rhinitis to tree pollen. And many people have multiple allergens that they're allergic to. You might have, some people have, we commonly test for 20 allergens that are common in this area, and some patients will have, 12, 14, or 16 of the 20 allergens that are positive. So that's allergic rhinitis. So non-allergic rhinitis is another entity, and that's on the far right of the slide. And what that means is that you develop symptoms to what we call non-allergic triggers. And you say, well, what does that mean? What it amounts to is these non-allergic triggers do not provoke the same response of your immune system that's called an allergy. So these are what we call non-allergic triggers. And examples of those would be things like perfume, gasoline, cigarette smoke, newspaper print, solvents, household cleaners, ammonium, newspaper print, some cosmetics, and so forth. These are all what we call non-allergic triggers. So when people are exposed to these kind of triggers, then they develop these rhinitis symptoms. And usually, well, by definition, these people, when you do their allergy tests, would have all negative allergy tests. And so if any of you in the audience have ever been diagnosed with non-allergic rhinitis, that's basically what they mean. Then mixed rhinitis is in the center of the slide. What that means is these are people that have both allergic and non-allergic triggers. So they have the allergy tests that are positive. They have some exposure to an allergen that confirms the allergic component. And then in addition to that, they self-report non-allergic triggers actually causing rhinitis symptoms. So those are the three kinds of rhinitis. Now, this is a study that looked at allergic rhinitis, and this was, they actually took patients from an allergy practice and diagnosed them with allergic rhinitis. And they went into a primary care practice, like that just is simply your primary care physician, and they basically found a group of people that didn't report any of these symptoms. And then they asked them, what symptoms, they actually filled out a questionnaire that helped them diagnose migraine. And what they found was that the patients that had allergic rhinitis actually had a higher proportion of them actually had migraine. In fact, you can see it approaches about 35%. And then those in the non-rhinitis group on the graph, if you read that, had about 4% prevalence of migraine. So there are a number of studies like this that would suggest that migraine is more common in people that have allergic rhinitis. A lot of the other studies just simply asked patients by questionnaires whether they had hay fever. And in those studies, they really had no corroboration that they actually had an allergy. They just self-reported that they had hay fever. And most physicians believe that hay fever often represents allergic rhinitis, although I would argue that maybe they might have mixed in a few cases of non-allergic with that. But nevertheless, there are a number of studies suggesting that migraine is more common in patients with hay fever as well. All right, well, I'm going to go to the next slide. Now, this is actually something we're going to be presenting, and I know that you guys probably aren't real savvy at looking at graphs, but I think from what you can probably see what is going on this graph. So on the y-axis, that's the vertical axis on the three graphs, that basically shows the number of migraine days per month that patients had in different groups. In the three graphs on the left, it shows allergic rhinitis versus a control group that had no rhinitis symptoms. In the middle shows mixed versus a control group. And on the right shows non-allergic compared to a control group. And if the group that has rhinitis is that little hatched kind of grayish line on the graphs. And all I really want you to notice is that, and then on the x-axis are something called the percentiles of migraine frequency. That's not really important for you to know, but just note that in all three cases, that the frequency of migraine headaches, the number of days that people have migraine headache, was greater in the rhinitis groups as compared to controls. And when we did all the statistics on it, this was statistically sound comparisons or differences between the two groups. It's called statistically significant. So the bottom line is, not only are the proportion of patients that have migraine influence, as you saw in the previous slide, but actually the number of migraine days per month that people experience are also much greater in rhinitis patients compared to controls. And usually and you might ask, well, how much greater is it per month? And if you can actually figure that out from the graphs. It really varies anywhere from about a quarter of a day more per month up to about 3 to 4 days per month. And I would argue that the average is somewhere about that the rhinitis groups, particularly the mixed group and the non-allergic rhinitis group seem to have more headache days than even the allergic group, because you can see there's a much greater difference between the hatched areas and the control group, which is in the black. So frequency looks like it's increased in rhinitis, and it looks like those that have some non-allergic triggers actually have an even greater likelihood of having a higher frequency than others. We did the same thing with disability of migraine, and we found that the rhinitis groups actually had a much higher disability than the control group as well. So it looks like it increases the proportion of patients with migraine, and also if they do have migraine, they're more likely to have frequent and disabling headaches if they have rhinitis. So I think with that kind of brief introduction, I think we'll open up to any questions, and hopefully this wasn't too complicated for you, and you can follow the slides. So we'll open up for some questions now.
All right, our first question is, I have frequent sinus and allergy headaches with congestion. When I treat them with medication, I end up with a migraine. Are there any sinus and allergy medications I can take that will give me relief without triggering a migraine?
That's a good question. I mean, it's very possible that in some of the nasal sprays that are used, at least with some patients, that there could be things that are in the propellant that might trigger headaches. In fact, there have been a few reports in the literature of like nasal steroids an example of one would be fluticasone, that sometimes can be associated with headaches, but that's highly variable. Most patients that take the nasal sprays tend not to have worsening headaches, and what I'll often do is basically change to a different nasal steroid, or I'll use something called an intranasal antihistamine, and there are a variety of those as well that can be used to treat the symptoms. And then finally, there are some pills that we can use to treat allergic rhinitis. One is called montelukast or Singulair, and sometimes we'll use that to treat allergic rhinitis. So inhaled steroids, inhaled antihistamines, and this montelukast, which is a medication, is often used for asthma, but it's also used in allergic rhinitis. Now, other things you can do if for some reason you had some sort of reaction to all three of those modalities, and you had some allergic component to the rhinitis, either allergic rhinitis or that mixed category where you have both allergic and non-allergic triggers, then you could try some different, neti pot, that could be used as well, where you kind of flush your sinuses out. And so there could be some other non-allergic or non-medication modalities that could be used to treat your headaches and rhinitis symptoms.
Thank you. Our next question comes from Nancy. High humidity and rainy weather seem to give me sinus headaches. Does the amount of moisture in the atmosphere point to any particular type of diagnosis?
Well, that's interesting. That's another study. You guys are hitting all the studies that we're doing right now. We're doing a big weather study right as we speak, and we haven't published any of the data yet, but so far it looks like the problem with looking at humidity and precipitation is that a lot of the weather variables are often occurring at about the same time. Like if you talk about a cold front rolling in, usually that's when you're going to get, you could get that, a warm front can cause rain too, but let's just take a cold front for example. What usually happens is there's a drop in barometric pressure that occurs about a day or two prior to the front rolling in, and it reaches its lowest point right as the storm front is overhead. And once the storm front goes through the area, what happens is if it's a cold front, you start getting a rapid increase in barometric pressure, and then you start getting the temperature starts to fall over the next 1, 2, or 3 days as the cold front kind of rolls through the area. Now, humidity oftentimes is associated with precipitation. So obviously, if you have 100% humidity, you're going to get precipitation with that. And oftentimes, well, it depends on what season it is, but usually, the humidity is really high when there's precipitation. And we did find in one of the seasons that humidity actually was provocative for migraine. And right now. It's really too early to really start reporting this data yet because I just saw the results today. So that's our study. There was another study that came out in children that was published about 1 or 2 years ago that suggested that rain and humidity was provocative of migraine attacks in children. But not all studies have shown that. So it depends on which study you look at, whether you're looking at adults or children and so forth, whether humidity is actually a precipitating factor. It's my belief that different patients probably have different weather triggers. I think maybe some people might respond to low barometric pressure. I think some people might respond to humidity and precipitation. I think some people might respond to thunderstorms, and there might be different electromagnetic waves that are released by lightning, and maybe in certain sensitive patients they might have worsening headaches. In fact, we're getting ready to report an article where we found that lightning actually was associated with about a 28% increased risk of migraine and about a 31% increased risk for headache. So the humidity thing is ongoing. Now, does that mean that you've got sinus disease if you've got humidity? We don't know the answer to that. We're looking into that right now as well to see whether people might be more weather sensitive if they've got rhinitis, but we haven't done the analyses yet. So, those are excellent questions, but we don't have all the answers yet.
Thank you. Our next question comes from Lori. I'm currently suffering from sinus and congestion issues, and I've only been able to take sumatriptan for headache relief. Does this present a danger of any sort?
No. I think there's often this overlap between migraine and in particular rhinitis symptoms that you can get. And it may very well be that particularly that non-allergic type of rhinitis, I'm beginning to think that kind of represents a very sensitive nervous system that we often see, and we often see that sensitive nervous system in both migraine patients and also patients that have non-allergic rhinitis. So, so it's not uncommon for patients with migraine to have rhinitis. In fact, in a recent study, about 60% of migraine patients actually have rhinitis. So there's this huge overlap between these two populations. We know that if people have migraine and rhinitis, that not only do the migraine headaches respond, but the ones that the patients believe represent sinus as well. So, and also we know that tension type headaches respond to Imitrex or those kind of medications. So we probably, with sumatriptan, we can actually treat the gambit of headaches we can do the gambit of headaches, both sinus, migraine, and tension type headaches with sumatriptan. There really is no interaction between sumatriptan and other allergy medications that we mentioned before.
Our next question comes from Jeff. I had sinus surgery almost 20 months ago, and I've had a constant sinus headache ever since. Only ibuprofen works to make the life bearable, but I have to take it every 6 hours. Could this be a migraine?
It could be. I mean, without knowing more about your history, it's hard to really say. But there's a few possibilities. One is that when you go in and start doing sinus surgery, there's a lot of things that can happen with that. One is you can develop scar tissue that might actually entrap nerves in the nose and in the sinuses that could then sometimes trigger headaches. In fact, a common scenario after sinus surgery that I've seen in a lot of patients is they'll tell me they got better for about 6 months, and then 6 months later their headaches worsened. And what I suspect is happening is that over time that they're developing more and more scar tissue, which is entrapping nerves. The other possibility is that with the sinus surgery, if they cut through some of the nerves, which they almost would have to, and somehow damage some of those nerves, that you could be left with some pain after surgery. The third possibility is that when they, depending on what kind of sinus surgery you had, but sometimes they go in and they open up, increase the size of openings, and it basically completely changes the way all the sinuses function to propel mucus out of the sinus. And then what happens is you get all this mucus that kind of just sits there in the sinus and doesn't get propelled out. And some people can develop recurrent sinus infections, even though the opening, the exit from where the sinuses drains is actually much bigger than it was before that. So I think there are a number of things that can actually occur that from surgery that could actually trigger more frequent headaches, although the opposite can actually occur. There are some instances where operating on your sinuses will actually improve your head pain, but it oftentimes doesn't get rid of it. And I think the reason for it is because oftentimes patients that have rhinitis, and even some people that have other sinus symptoms and headaches, often have migraines. And consequently, they might be able to take care of the sinus abnormality. And in some cases, if that was triggering the headache, it might help. But in some cases, maybe it wasn't. And in that case, the sinus surgery didn't help you. And if you had one of the complications that I mentioned before, in some instances, it may actually harm you. So you just don't know what's going to happen with the sinus surgery. I mean, I myself had a deviated septum about 20 some odd years ago, and it was actually pushing against the wall of my nose, and my headaches were all occurring behind my left eye and my left temple, which would be a common place where sinus pain would be referred. And I had to make the decision as to whether I was going to have my deviated septum fixed. And at that point, I was having a lot of nasal congestion, a lot of runny nose, and almost virtually daily headaches. I elected not to have my sinuses treated with surgery, and I just treated it myself medically. So I made sure all my rugs were clean in my bedroom. We effectively washed all the rugs because I knew I was very allergic to dust. I went onto a nasal steroid. I went on to a migraine preventative. I did a lot of other different things, and it was really interesting. There was not one thing that was a magic bullet for me in terms of my headaches, but each thing improved things by about 15 or 20%. Like I woke up with a headache every day for 10 years, and what I did was I went on these nasal steroids, and I cleaned my rugs in my room, and all of a sudden, for the first time in 10 years, I stopped waking up from a headache. And I guess you could argue that was placebo, but I think not. I think that I had allergies that were triggering my headaches, and who knows, I might have even had a mild case of sleep apnea, which can sometimes happen with rhinitis as well, because if you can't breathe at night, you tend to breathe through your mouth and you tend to snore more. So it's possible that sometimes treating rhinitis can help that. But to get back to your question, I elected not to have surgery in my case, and my headaches eventually almost went away. But so sinus surgery can be a very dicey thing, and you just can't be sure of what the eventual outcome is going to be.
Our next question is from Deborah. What is your experience with using saline sprays on a regular basis? Is it helpful?
Well, there's no studies on that, but I do think that is helpful. I think anything that moisturizes your nose and anything that can kind of open your nose or clear out any secretions, which may not be getting drained very often, I think saline nasal spray can be very effective in some patients.
All right. Our next question is, what kind of medication do you recommend for people that develop migraines from allergies? I often get a horrible migraine when molds are high outside, but normal decongestants don't really help the migraine.
Well, that's probably because in addition to just causing congestion of your nose, the mold or allergens actually cause your immune cells, your white blood cells in your nose, to secrete various chemicals that can actually activate the nerves in the nose, which might actually provoke headache. And it's interesting that you ask, well, what can be done? We published another article about a year ago in patients that had allergic rhinitis, and we found that we looked at a subgroup of patients that were younger, less than 45 years of age, and those patients that received allergy shots that were less than 45 years of age had a 50% reduction in the frequency of migraine attacks. And that's probably the largest study to date looking at allergy shots in migraines. So that's one thing that you could consider if you're less than 45. We found that in patients over 45 that the allergy shots did not seem to play much of a role. So that's one thing that you can do. And then I think The other things would be, as we talked about before, really doing a hardcore press on other kind of medications that might modulate this immune response that we call rhinitis. So one thing could be to go on a nasal steroid and maybe take a nasal antihistamine. Maybe you could take a nasal antihistamine. You could take a decongestant along with that, and then you could use a Singulair kind of in combination, and sometimes that can make a big difference. Now, the other thing that seems to work very well in allergies too, or in people that have sinusitis or sinus headaches, is if you go through a really bad run during allergy season, sometimes you can take a course of steroids, like oral steroids, at moderately high doses for about a week or 10 days, and sometimes that can dramatically improve your headaches in the short run. So there's a lot of different things, and the steroids actually modulate your inflammatory system, all the white blood cells that are involved in the allergic response. So I think there's a number of things that you can do.
Are there any allergy treatments that have been proven to actually reduce the frequency of migraines?
There is a new study that just came out, one of my partners did, where he looked at intranasal capsaicin in patients. This was just in patients with non-allergic rhinitis. So it was a group of patients that had rhinitis and negative allergy tests, and they had these, basically upon exposure to various chemicals, they would develop rhinitis symptoms. And he found that if you gave this intranasal capsaicin, which is the same thing as hot chili pepper, it's a chemical found in hot chili pepper, so it actually stings when you put it in, that when that was administered, that actually not only did it improve the rhinitis symptoms in non-allergic rhinitis patients, but it also improved the headaches in those patients too. Now they didn't really classify what types of headaches they were, but there was an improvement in headaches as well. So, and I think that data is still very preliminary at this time, but it's still something that's worth mentioning. Now, the one medication I mentioned called montelukast, there was one what we call randomized controlled trial of montelukast in all migraine patients. So it just didn't look at the patients that had allergies, but they looked at it in all patients and did not find that medication was more effective than placebo in preventing migraine headache. But I think in that study they looked at the wrong patient population. If they would have looked at patients with allergies and headache, I think they would have seen a much more robust response. So there's not a lot of data on allergy treatments and migraines to date. There's just a lot of anecdotal data at the present time.
Our next question comes from Stephanie. Is it unusual for someone's primary symptom for allergies to be a headache and not the other typical symptoms like a runny nose or itchy eyes?
Well, it depends. Allergy can take a lot of different forms. All we've talked about were airborne allergens. That would mean the different things that you breathe in through your nose causing allergic rhinitis. But there are also some people that will develop allergies in general, and that some of them will have actually food allergies. And there's some data back from the 1980s and 1970s looking at food allergies in migraine. I'm not going to tell you that it's really great research, but it is out there, that there are people that seem to have food allergies. So they'll basically get skin prick tested for 100 allergens or 100 different foods, and they'll find a certain percentage of those will be positive. And then they ask those people to avoid those foods, and then they would reintroduce them back in some sort of blinded fashion to see if migraine was triggered. And those are called, double-blind, placebo-controlled food challenges. So they either get placebo or the actual food that they were supposedly allergic to on the skin prick testing, and they found that about a half of those people that thought they had food allergies or that were identified on skin prick testing, maybe half to two-thirds, when you reintroduce the food in a blinded fashion, it would trigger a headache. So it is possible that you could have allergies to food but may not have any rhinitis symptoms whatsoever. There was a recent study where they looked at these things called IgG antibodies. Now, it's not truly a allergic response. It's a blood test that you can get, and it basically identifies foods to which your immune system is responding, but it's not a true allergic reaction. and they did a study where they randomized half of the patients to foods that were thought to be positive on this testing, and then they had the other half of the patients were randomized to foods that that were found not, or encouraged to eat foods that they were not having this immune response to. And what they found was that compared to their baseline, the group that was randomized to the foods that were thought to be having an immune response to had about 26% higher frequency of headaches than their baseline, but the group that were randomized to the foods that were not provoking an immune response were no different than than baseline. So this was actually the first double-blind trial to suggest that some foods to which people had an immune response, and some people might even call it an allergy, although technically that's not correct because it's not the type of immune response that really is an allergy. But by identifying these IgG antibodies, that you actually could actually theoretically come up with a diet that people might actually respond to. But the problem is that they oftentimes will test you for like 100 foods, and they may find 25 or 30 of the foods that are positive. And oftentimes what happens is they're often foods that are very common in your diet. So you might have to be asked to avoid gluten, or you might be asked to avoid dairy, or you might be asked to avoid eggs, or if you're Italian, you might be asked to avoid tomatoes, which is a big deal to me. I don't think I could stop eating tomatoes because of my heritage, and how much I love Italian food. But what happens is the diets become extremely restrictive, and you have to be careful on some people because they can almost make people nutritionally not healthy. So I think when I do this kind of testing on people to identify these immune responses to foods, which a layperson might call allergies, but technically it's not. You have to just use the foods that have the highest response on the immune system. If you avoid all the foods, it becomes rather problematic. So you could have allergies triggering headaches, particularly if they're ingested by mouth, that may not have rhinitis symptoms. And there might be other things too, like if people have bee sting allergies, they get swelling or something called anaphylaxis to bee stings. Sometimes those people will have headaches too, but those tend to be hopefully rather infrequent episodes.
Bob would like to know, are there any effective treatments for weather-related headaches?
That's a great question. We don't know the answer to that, but I believe that, and I am hoping that we can prove this, I believe that weather-related headaches, the people who have rhinitis probably are more likely to have weather-related headaches. That's one of my hypotheses with some of the research that we're doing right now. And if they have weather-related headaches, then theoretically, if that were really true, then you could like decongest yourself during, when these fronts roll in, maybe with some, Afrin nasal spray or something like that, when you start getting congested, and maybe you could ward off a headache with that. Or maybe we also know that headaches that originate from the sinuses tend to respond very well to anti-inflammatories. So things like high-dose ibuprofen or Motrin, particularly if you were able to predict which weather patterns were provocative for you, then you might try some therapies that maybe even before you develop a headache that would stop you from developing the headache. But the first step in this weather relationship is number one, to figure out what kind of weather parameters or weather variables actually trigger your headache, whether it's low barometric pressure, whether it's humidity, or whether it's precipitation. And each of those may differ in terms of what you might want to do. Like if it were low barometric pressure, you may be causing some sort of a vacuum phenomenon in your sinuses. With those kind of headaches, I would anticipate that maybe decongesting you might make a big difference. If it was being triggered by other things, like let's say that like the wind speed or something kicks up allergens in the environment, if that were the cause of your headaches, indirect, so basically it's causing more allergens in the air because of the weather that you have, for that time, then you might need to treat with other allergy therapies like we talked about before. So that's a very, very complex question. So, but I think we need to figure out, number one, which weather factors trigger headache in migraine patients, and you have to figure out which subgroup of patients, and which subgroups of patients respond to which triggers, and you have to develop different therapies probably for each individual weather factor, and then it will be helpful to have some sort of prediction mechanism to try to predict headaches before they happen, much like they try to predict the weather. Maybe there could be some sort of weather index that helps people predict medical illnesses. So it could be a whole burgeoning new area of research in the headache field.
Carol is 71 years old, and she's suffered from migraine since she was 19. She's recently been diagnosed with asthma. Is there a connection between migraines and asthma?
Yes. First of all, rhinitis and migraine are highly related to one another. So it's possible that even if asthma was shown to be associated with migraine, that we don't know whether it's the asthma or the rhinitis. But we do know that there are many studies suggesting that patients with asthma have a higher likelihood of having migraine. And why that is, we don't really know. But it could relate to, whatever causes, asthma, whether it be, allergies, or there's also this neurologic component to asthma too. That just like in rhinitis, there's a non-allergic and allergic, or rhinitis and asthma, there's an allergic and non-allergic asthma as well. And it looks like it's the non-allergic rhinitis that seems to be more likely to provoke or to be associated with migraine than the non-allergic. So, which probably identifies that there's some sort of neurologic component to asthma that is somehow linked to migraine. I think that's probably what's going to be the real connection, is that the neurologic component of asthma is likely the same thing that's leading to migraine in the brain, but they're just different parts of the nervous system contributing to both disorders. There are other possibilities too with asthma. One is that maybe some of the therapies that you take for asthma, some of what we call the beta-2 agonists, that's like albuterol and so forth, that some of those will actually trigger headaches too. So it's possible that in some cases it may not be the asthma, but it may be the treatment of the asthma that might actually be provoking some headaches in people. So it's a very complex question, I think one that needs to be looked at, and we've got the data in our data set to look at that after we get done with our rhinitis study.
Colleen occasionally gets pressure around her eyes and forehead. This causes sleepiness with only a mild migraine. She says that I do have non-allergic rhinitis. Is it common symptomology, and do I treat this with nasal steroids or just usual ibuprofen?
Well, it's a great question. You raise another issue, is this whole issue of pressure over the sinuses. The way I look at migraine is there's three components to migraine. There's the migraine pain, which is the really severe pain. And then there's the tension pain, where maybe the headaches don't reach migraine proportions, they don't have the nausea and sensitivity to light and noise. And then the third component, kind of the lowest level of, I wouldn't even call it headache, but is this pressure sensation that people get. And what we found in some of our studies is that if you have migraine or tension type headache and you have pressure, then what you find is that your headaches tend to be more frequent and more disabling, which I think is a very interesting finding. So it looks like that this pressure sensation people get seems to predict more severe migraines, or more frequent migraines and more disabling migraines in people that don't have pressure. And about 80% of migraine patients report pressure over their sinuses, which I think is fascinating. 80% report, besides the head pain, they get some pressure over their sinuses. So you say, well, what's causing that? I think what's causing it is when you have a migraine nervous system, you have this hypersensitive nervous system. It probably picks up all sorts of changes in your head and in your sinuses, because that nerve goes to the sinuses. So consequently, what happens is, you probably get, anytime there's nasal congestion or a sinus gets clogged up with secretions or whatever, it perceives that as a pressure. Whereas if you don't have migraine, it's much less likely to occur. So the presence of pressure, I think, is something that's very important. Now, I would suspect that pressure sensations are to a large extent occurring from this vacuum phenomenon that we talked about, where a sinus gets blocked and you get this kind of, like, the sinus kind of, this pressure kind of drops and kind of starts, it causes negative pressure in the sinuses and starts to pull on the membranes, and that probably activates the nerves that cause head pain. And I believe that probably the sinus pressure is going to be best treated by treating, with some sort of decongestant or frankly a nasal steroid. But the nasal steroid is going to work over days. It's not going to work, extremely quick. The decongestant will work very, very quick, particularly if you were to administer it in a nasal drop formulation like an Afrin or some sort of Afrin equivalent. But what you don't want to do is you don't want to take that for more than about 2 or 3 days at a time if you're going to be using a nasal spray, because you can develop a dependence on that, and every time you don't use it, your nose swells completely shut. So if you're going to have to use decongestants, like Sudafed, then you probably want to use that more in an oral form over a period of time, or combined with an antihistamine. There's like a Zyrtec D and a Claritin D and so forth that are tablets that might help the pressure sensation. And then if you want long-term improvement from the pressure, then one could use a nasal steroid or a nasal antihistamine that we talked about before. There's one called Astelin is the trade name for that. Now, the anti-inflammatories I think I mentioned are very effective for pain originating from the sinuses, at least so the ENT physicians believe. And it's very possible that maybe you could treat the after effects of the sinus problem on the nerves by treating with an anti-inflammatory, and that may help your sinus pressure. So if I had to use a pain medication, I would use an anti-inflammatory for that.
Thank you. Our next question comes from Robin. I've heard that there may be a connection between artificial sweeteners and migraine. Is there any verification of this?
Yes. There are actually three studies looking at aspartame with migraine, and 2 of them were positive and 1 was negative. But some of the studies that were positive were accused of using really high doses of aspartame, so high to achieve the consumption of similar quantities, you would have to have drank like 3 or 4 liters of diet soda. So, but 2 of them showed that, one showed that headaches were increased by aspartame, and I believe it was in migraineurs. The other showed that migraine was increased, and then one study was completely negative. There have been some other, reports of Splendid and some other things triggering migraine. They're all just case reports. They're just basically individuals who believe that those were actually triggering headache. And I think there was one study that actually used a placebo to see if the patient could be fooled into saying that they had headaches. It was placebo versus the sweetener. And in like 1 or 2 patients, they found the patient was pretty reliable at identifying sweeteners as triggers. So I think that, and there are in some cases that could trigger headaches. I know that when I was much younger and having the headaches that I described earlier, that whenever I had a Diet Coke, and at that point they were putting aspartame in the Diet Coke, that I would develop a headache after that, and I eliminated that. It seemed to help. So a lot of the data on this is anecdotal, with the exception of aspartame, where there's some randomized controlled trials.
Llewellyn would like to know how she can effectively treat her sinus headaches without causing rebound headaches.
Well, that's another good question. You guys have given me a bunch of great questions today. There is some weak data to suggest that if you use decongestants on a daily basis, that they might generate rebound headaches. So there is the possibility that those could generate rebound headaches. I think when I'm treating my sinus disease, I try my best to not use the decongestants all the time, maybe more episodically when nasal congestion is really severe. I try to go more with the nasal steroids and the nasal antihistamines that we had talked about before. And then the anti-inflammatories, which I mentioned before, were very effective for pain, generating from or originating from the sinuses. Of all the analgesic medications, are probably the ones that are least likely to promote rebound headaches. But they probably still, in some instances, can trigger these rebound headaches. For those of you who don't know what rebound headaches are, they're headaches that are actually generated by the overuse of medications. We tell people we like to keep people from using more than their acute pain medications more than about 2 days per week on average. And if you start using more than that, there are many people that believe that can trigger head pain. So what I would suggest is if you have to use anti-inflammatories, try to keep it to no less than 2, maybe 3 days a week at the most. Try nasal steroids and nasal antihistamines, and maybe singular if you've got an allergic component to your rhinitis, and give that a try. And then, if you run into a really bad allergy season, I can tell you that steroids work very, very well to get you through that tough time. As I mentioned before, the prednisone. And I think those are the things I could recommend at this time. And then I think saline rinses and sometimes, the neti pot can be effective as well.
Thank you. Our next question is from John. Are there really sinus headaches when there is no sinus infection, or are they migraines?
Most headache doctors would tell you that there is no such thing as a sinus headache unless you have an infection. I believe that that's probably not true. I believe that many people with rhinitis probably do have the migraine nervous system, that would kind of go along with what many neurologists and headache experts believe currently. But I believe that it goes the opposite way as well. I believe that if you have these non-allergic triggers, or if you have the allergic triggers that act on the nose, that can either trigger nasal congestion, or it might release other chemicals from the inflammatory cells in your nose that can trigger headaches. So I believe it's kind of this vicious circle. So migraine is more common in patients with rhinitis, but I believe that migraine and tension type headache are more frequent because of the rhinitis as well, namely from the allergic and non-allergic triggers to which migraine patients are exposed. I think it's basically a two-way highway. But that there is controversy in the headache field, and I think actually the data that we're going to be presenting at this meeting in 2012, of which I shared with you guys in the slides, one of which is up on the screen right there, will start to change some people's minds about the importance of rhinitis in terms of migraine frequency and disability.
Next question is, can Butterbur be taken along with Topamax?
Yes. Butterbur is one of the only, herbal remedies that actually has 2 randomized controlled trials that would support its efficacy. So it's probably the best studied of the herbal remedies. And the study that I think was the best used a dose of either 50 or 75 milligrams twice a day. Actually, the 75 milligram appeared to have, at least numerically, slightly more improvement than the 50 BID dose. And I've had some pretty good luck with Butterbur in some patients. I can't tell you whether that is something that would work more or less in sinus patients, but it can be a very effective preventive therapy. But remember that any preventive therapy takes anywhere from 2 to 4 weeks to even start to work, and you just need to give it time. And a good response to preventive therapy is a 50% reduction in the frequency of migraine headaches. So it's not a cure. So you have to keep that in mind, is that we don't have a cure for migraine because it's likely a disease of the central nervous system.
All right, our next question. I've tried allergy shots and had severe reactions to them. I am hypersensitive to all medications routinely used for migraine, and I've experienced most of the side effects associated with these drugs. In your opinion, what would my next steps be?
Well, people like yourself are some of the most refractory headache patients because, you end up having, side effects to almost every medication that we try. In fact, I had a patient the other day that they literally had tried, oh my goodness, it was probably 25 different preventive medications, and they had intolerance to probably 2/3 of them and just didn't respond to the rest of them. So they were very intolerant to any medications and so forth. There are some people that are just so super, super sensitive that they just don't respond to medications. And what I would have to say in that situation is that you need to take different approaches. So medications are only half the game. You know, you have to learn how to change your lifestyle, identify what your trigger factors are, treat, you know, the trigger factors that you can. You know, so identify your dietary triggers. Maybe you want to do some of those IgG food tests and see what foods might be triggering your headaches, and try to eliminate at least the ones to which you have the highest reaction. You want to exercise, and that can help your headaches. You want to keep yourself hydrated. You want to avoid caffeine or caffeinated beverages. You want to not overuse your abortive medications, you know, if you're able to tolerate those medications. But I will tell you that it does represent a refractory group of people. Other things, you can try biofeedback and relaxation techniques. Sometimes that can be helpful. If there's a trigger in your neck, or if TMJ triggers it, you might undergo physical therapy or some sort of treatments for those disorders. So it's basically looking at the whole patient and trying to figure out, you know, which triggers that you may have, and it really comes down to working with your doctor on probably over weeks, months, and sometimes years to see some improvement in the headaches. There's often not a quick fix for those type of people, but there is help. So I think that probably ends the questions at this point, because our hour is over. But I want to thank you all for participating in this conference, and I hope that that you can improve your life with migraines through a variety of different abortive and preventive therapies. And I would only leave you with one thought, is even though the headache community may believe at this point that your sinuses and your allergies and so forth may not be triggering your headaches, I think there is evolving evidence to suggest the contrary. And not to say that everyone will be helped by these therapies. There seem to be subgroups of patients that might benefit from these therapies, and with future research, hopefully we can uncover which patients might benefit the most from these types of therapies. Thank you very much.
I'd like to thank you, Dr. Martin, for joining us, and I'd like to thank everyone else for participating tonight. And I want to remind you that June is Migraine Awareness Month, and we have 2 chats left this month. It will be tension headache and hormones and headache. Please feel free to join us. You can sign up at www.headaches.org. Have a great evening.